Joins us now, a cardiologist and executive director of health and community education with Piedmont Healthcare. Dr. Morgan, thank you as always for coming on to discuss this major issue that is terribly concerning. So tell us about specific types of medical equipment and those algorithms, how they have racial bias, and why does it happen?
And so we see a number of examples. And if we look at the pulse oximeter is a little device that will clip on the end of your finger when you're in the emergency room or in urgent care, or even your doctor's office, measures the amount of oxygen that's in your blood. But that device works by light that passes through the skin. And so the more melanin and more pigmentation you have in your skin, the more that light is blocked and the more inaccurate that measurement is. And what that means is you can be in an emergency room and have a low oxygen level, but that machine may read it as normal, and then you are triaged to a lower level of care and concern. You may have to sit and wait while patients who are more urgent than you are seen ahead of you, even though you are sick and probably deteriorating, but that pulse oximeter does not read correctly. We see the same thing with forehead thermometers. Many people became familiar with those as we were at the height of COVID. They were used often to screen people either in or out of facilities. And these forehead thermometers work by very similar technology. And a study out of Emory University actually demonstrated that the more melanin you have in your skin, the less accurate these forehead thermometers are when you have a fever. The higher your fever, the less accurate they are. And in fact, Emory went one step further and used the old-fashioned mercury thermometer that you put under your tongue and found that those measurements were more accurate in people of color.
I mean, that's just so horrible to hear, especially given the past few years, those technologies have been so needed to diagnose COVID, but it goes far beyond that as well. What are some of the dangers that this poses for people, and what advice would you give folks who maybe are worried this could happen to them?
Lindsay, that is such a great point. When we look at kidney function, we measure it by something called the estimated glomerular filtration rate, or EGFR, and every doctor utilizes this to make decisions and to provide guidance to their patients. This is a calculation that is generally done in the pathology lab. Most doctors know the formula, but we haven't used it since medical school. Pathologists do that formula for us, and it has actually a race multiplication factor in it. That is actually called an AA factor for African American. It is specific only to the Black race. And when you get to the end of that formula, if you are Black, there is a multiplication factor that will artificially increase that glomerular filtration rate or increase your value, and it makes your kidney function appear better than it really is. What that means is, again, you are triaged to a lower level of care and concern. You are late to start medications that may be helpful to your kidney. You have referrals late to specialists. You go on to kidney transplant lists late. In fact, the Oregon Procurement Transplantation Network Board, just this month in February, has asked all transplantation centers in the United States to not only identify Black patients who should have gone onto transplant lists, but to notify them and to provide some rectification for these patients who have been denied or delayed kidney transplants because of this formula that is pervasive throughout all of medicine.
So do patients need to, really quick here, do they need to really advocate for themselves more moving forward until this is addressed more fully?
Absolutely, patients need to advocate for themselves, make certain that you have the information. Many doctors are beginning to understand and hear about this. We see hospitals moving in that direction. The kidney area is moving finally a little bit more rapidly than some of the other areas. We certainly want to challenge spirometry, where we measure lung capacity. That is built into the software of those devices, and the software itself automatically calculates a 15 to 20% decrease in lung capacity if you are Black and 5 to 6% if you are Asian. And so once again, you are late for referrals and specialized care. And so we absolutely want to make certain that we advocate and move that forward, and patients need to be aware of it as well.
All right, Dr. Jane Morgan, thank you so much for coming on. As always, we appreciate your time and your insight on this topic. Thanks again.
Thank you, Lindsay.
We'll be right back.